So, a big welcome to everyone and a good afternoon to everybody. Good morning and good evening to those in other parts of the world that's joining us from Canada or wherever you might be. It is really an exciting day for us. So many people have spoken to me in the last week with excitement about today's session, knowing who is coming to speak. But I'm not saying anything because that is Dr. Karen Günther's job today to chair the meeting. As you know, I'm just the housekeeper. So she will give you a bit more details in a moment. But just to remind you of some of our housekeeping issues. So all the sessions that are hosted here are recorded and are now on the Blood SA website. And I really want to encourage everyone to go and visit our new website. We're very proud of it, very excited about it, but I have also have to say we're still in the process of fine-tuning it, and the team is working on it every day. So if you see anything that can be improved or that glitches, let us know. We'll be very happy to do that, of course, as soon as we can. We really want to encourage everyone to use this opportunity. You know, it's fantastic to have world-class speakers on this platform, and we've been very fortunate to have world-class people on a regular basis. But the moment and the opportunity to speak to someone live in the moment, ask your question, you might have a patient with an interesting situation, please use it. The moment is now. And today we've really left enough time for discussion. So that will come a bit later after the talk. The sessions are CPD accredited. So at the towards the top of the hour, I will add a link so that you can register for CPD points. That will take you probably 30 seconds to fill in just your very basic details. And we do it on your behalf directly with the Health Professions Council if you are from South Africa. If not, please email Melanie at the email address you can see there so that we can assist you with a different form of certification. Now, it is my great pleasure today to ask Dr. Karen Günther, who I'm sure is known to everybody here, but Karen is a clinical hematologist who works in Johannesburg. She is my role model. If I think of people who would go all the way for every patient, she's the one. If she does not give up, she will find something somewhere, even if it's in outside the country, she will find an answer. So thank you, Karen. You inspire all of us in the way you passionately pursue treatment for patients, and this has been a consistent part of your character as long as I've known you. So with that, I'm handing over to you as the chairperson of the afternoon to introduce our guest.
So wow, it's such a privilege to introduce Professor Moti. There's people who speak at meetings who have done great trials and give us data. And then there's people who really clearly have such an in-depth understanding of subjects and can teach in an unbelievable way and can really give you insight. And that's where Professor Moti is really unparalleled. Before I tell you his amazing CV, I just want to say that the thing that is most amazing about him is how accessible he is. And I'm going to sail you down the river now, because if you email Professor Moti, he will help you. So speak to him if you've got difficult cases. I hope I'm not doing you a disservice to do this, but I never cease to be amazed that someone of your stature is prepared to help and talk on a basic level to all of us. So we greatly appreciate that. So just to let you know the stature of the person you're talking to, he is a full professor, head of the hematology department at St. Antoine Hospital. He was a past president of the European Bone Marrow Transplant Society. We've had the privilege of having him in South Africa a few times. I'm sure some of you would have met him in person. He's the chairman of the Acute Leukemia Working Party of the EBMT. He's the founder of the International Academy for Clinical Hematology. That is a fantastic source of information, lectures. I hope most of you know how to find those. There's amazing podcasts and things which you can get in all subjects from that. And I always laugh at these numbers. In addition to publishing more than 800 peer-reviewed articles, he's also the editor-in-chief of the journals of bone marrow transplantation, clinical hematology international. He really is amazing. And just one final thing to say is, just as Vernon just said, you know, if you go to ASH or EHA, you will see Professor Moti, but we can't get near these people. They stand on a platform, they have so many questions. We have such a privilege to be able to actually ask him face-to-face questions now. So please, please make the most of this opportunity. So Professor Moti, if I can hand over to you, and we're so interested in what you have to say.
Thank you very much for the kind introduction. Thank you, Dr. Louvre, Dr. Günther, for the kind invitation. And I would say, Dr. Louvre, you can be proud not only of the platform, because you mentioned this, but you can be proud of the whole educational activities and work you are doing for the benefit of patients in South Africa and beyond. And for Dr. Günther, he mentioned that you will always do the extra mile for any patient. And I can personally confirm this, because a few minutes ago, we were talking about one of these young patients where we communicated by email to see how we can help in sometimes desperate situations. And this is really a true pleasure to be with people like you, all of you guys, dedicated, devoted, with lots of passion to help the patient in a not always easy environment, I think, and we need to acknowledge this. So thank you again for having me with you. I'll be there whenever you want. It's a true delight to join my South African colleagues, and thanks to the organizing committee and the company who facilitated the technology, etc. So for this afternoon, I've been asked to discuss some approaches to the management of relapse refractory multiple myeloma. And it is actually a very exciting topic, but you will see it can be also very frustrating, because we do have a lot of options. Not all of them are available or accessible everywhere, but one thing for sure is clearly there is a lot of hope for myeloma patients. These are my disclosures, and by the way, these are my own slides. I did prepare them on a weekend. I forgot whether it was last one or the one before. Nobody controlled them. However, I've been asked to put a disclaimer here for the supporting company. And just for the sake of introduction, for the youngest colleague in the room who always think, you know, that things were always the same, you know, it's like, you know, my children, your children, they always think that we had Twitter, we had internet, we had, you know, but then sometimes you say, hey, come on. I did my university, I didn't have Google, and I didn't have all of this fancy stuff. So actually, a few months ago, I moved office because we were refurbishing the department, and it's always a good opportunity to tidy up your office and see all of these old books. And I had actually my Principles of Internal Medicine from 1994 when I was a resident. And so, and it was quite brand new, actually. Probably I wasn't a good student using it a lot, but actually I opened it to the myeloma chapter, and I could read about 15% of myeloma patients die within the first 3 months after diagnosis, and subsequently the death rate is about 15% per year, and the disease usually follows a chronic course for 2 to 5 years. And obviously 5 years at this time was definitely a miracle, because it was rather 2 to 3 years, as I have been taught at medical school. And that was written in 1994, so not really 1 century ago. But since, we've seen the advent of an amazing number of new drugs and new agents. And while we lived for almost 40 years with the classical chemotherapies and steroids, namely prednisone, dexamethasone, melphalan, low-dose melphalan, cyclophosphamide, and a few combinations here and there about adriamycin, vincristine, etc. The key advances occurred first in the mid-late 90s with the validation of the role of high-dose melphalan, and this is what we call today autologous stem cell transplantation, the first cases being published in the mid-80s without stem cell support, and then you had the validation in randomized phase 3 trials thanks to the IFM study, the IFM 90 study, but also to another study from the UK. By the late 90s, early 2000, we had two big families of drugs. The IMiDs, and you have the grandfather thalidomide, the father lenalidomide, the grandson pomalidomide, and soon the grandson like iberdomide and mezigdomide. In parallel to the IMiDs, we had the proteasome inhibitors, and the first in class was bortezomib, Velcade, generic drug now. But then we had the second generation proteasome inhibitors, IV carfilzomib, but oral ixazomib. And actually, we lived with these two big families, the IMiDs and proteasome inhibitors, I would say roughly until around 2014-15, where we have seen the introduction for the first time of monoclonal antibodies in multiple myeloma. And this is about two type of antibodies, two targets, the SLAMF7 as a target, anti-SLAMF7 elotuzumab, but also CD38 as a target with daratumumab and isatuximab. In parallel, we had HDAC inhibitors like panobinostat, although this is not the most popular drug these days, but also we had XPO1 inhibitors like selinexor, which are trying to find their place, I would say, in this very complicated landscape. And you can see that initially it took 40 years, then it took 10 years, now it took 5 years to move to the next step, because since 2020, we had the approval first CAR T cell, ID cell, and recently another CAR T cell construct, cilta-cel. And more recently, and that is from August 2022, we had the approval of the first bispecific antibody or T cell engager, namely teclistamab. And I will show you that this is a very, very rapidly evolving field. The good news that when you consider a treatment with VRD, bortezomib, lenalidomide, dexamethasone, and I think they are becoming now generic combinations everywhere, and auto transplant. You may have seen this New England Journal of Medicine paper from end of August this year by Paul Richardson and colleagues, was a relatively long-term follow-up, clearly showing the advantage of VRD induction, auto transplant, and lenalidomide maintenance. And when you look to these overall survival curves at 7 or 8 years, we are very, very, very far from the 15% mortality, every year, as it has been described in my textbook of the Harrison Internal Medicine textbook. So patients are living longer. And we believe today, according, for instance, to the IFM databases, that those patients with standard risk multiple myeloma are likely to live more than 10 years in median if you apply the modern regimens. That is the good news. The bad news is that, unfortunately, these curves, the curves you have just seen, are not flat curves. There's no plateau, and patients are not cured. So we do have patients who will continue to relapse, unfortunately. And myeloma is a very complex disease. And actually, when we speak today about multiple myeloma, it is about different diseases, and at some point in the next few years, I'm fully convinced that in myeloma, we'll have a similar story to lymphoma, where you'll have different entities, or to AML, where you have also different entities. So the molecular, I would say, identity of these different subtypes is going to be deciphered. And actually, we already know, for instance, that there's a small group, not really small, a significant subgroup of patients with translocation 11-14, where you can use a targeted therapy. So I'm convinced that we will dissect the disease into different entities. But while waiting for this, when these patients are relapsing, unfortunately, the response will decline over time. So what does that mean? I think it means that our focus should be the first line treatment, but also the first or maybe second relapse. Because actually, when you dig a little bit deeper, and if you look into your own patient in your center, go back to your patient from the last 2 or 3 years, I'm convinced you will discover that 80% or 75% of the amount of survival that has been accumulated by a given patient has been actually achieved through the first line or the second line, the first relapse. So it's very important, although we are all excited when we go to ASH, to EHA, to see these slides with patients who received 18 lines of therapy. That is not, I think, the real life. So it's very important not to miss these early lines. However, when it comes to choosing a treatment for relapse, unfortunately, and although I know we all have fantastic smartphones and iPhones, and some of them are able to prepare my coffee, in the morning alone, I do not have a smartphone and an app that allows me to guess easily the right relapse treatment for a given patient, because it is about frailty. It is about aging, and we know that frailty increases with age. We know that the aging process is not the same in all patients. It is about the number of comorbidities, and whether we like it or not, myeloma is a disease of the elderly, although I appreciate that depending where you are, if you are in Scandinavia or Germany, we're talking about the very old myeloma patient. In countries like in the Middle East, like in South Africa, I think you see younger patients with more aggressive diseases. And there is slight differences in the epidemiology, of course, and you probably, everybody knows that there are also some ethnic correlation with the outcome. And we know the data from the Afro-American patient that these patients have more aggressive disease. Also, we should not forget that when we're talking about relapse, it means patients received the prior therapy. So they may have accumulated some toxicity, and you have to take this into account. The other important finding is that it is a very dynamic disease, and actually the number of bad cytogenetic abnormalities will increase, will accumulate with time. And last but not least, the resistance to a specific drug class will develop at some point. So all of these factors, when you put them together, create a sort of a complex equation to find the ideal option for a given patient. A key feature, in my opinion, in the choice of a treatment for a myeloma patient is about the lenalidomide refractoriness or sensitivity. So what does that mean? Today, I think, especially with lenalidomide being widely available as a generic drug, lenalidomide is used almost continuously in many patients for maintenance after transplant, but also in the non-transplant setting. So there is one thing you can be sure about, is that a great number of these patients will become len refractory, as we say. And the outcome of these patients is going to become dismal, because the IMiDs are an important family today in the management of these patients. But also, actually, it creates a sort of different scenarios to be handled when choosing a sort of a lenalidomide-free regimen to handle relapse. Especially that these patients with lenalidomide refractory disease will have a very bad outcome. And you may remember that in the 5, 6, 7 years ago, most of the regimens that were developed in the relapse setting were actually relying on lenalidomide. I'm sure everybody is aware of the Pollux trial, Dara-Lendex, the Aspire trial, Carfilzomib-Lendex, the Tourmaline 2 trial, Ixazomib-Lendex, the elegant, forgot number of elegant trial, Elotuzumab-Lendex, because none of these trials anticipated that the majority of the patients will become len refractory, because, for instance, today we give len after maintenance after auto for maintenance. In the elderly, we're giving Dara-Lendex in many patients, or Lendex alone if Dara is not available. So patient will become len. So in order to set the stage on how to choose the right regimen, I'd like to share with you the case of, I would say, everyday patient. I'm sure everybody in the audience have seen such patient, 51-year-old, previously healthy gentleman, symptomatic myeloma, hypercalcemia, anemia, lytic lesion. There's no problem with the diagnosis, very straightforward, like at medical school, you know, IgG kappa, revised ISA stage 3, normal LDH, normal cytogenetics. So that's good news. No bad cytogenetics, not high risk. This guy has been treated in an academic center, standard of care a few years ago, VRD induction, 4 cycles, high dose melphalan, lenalidomide maintenance. As you may guess, 2.5 years later, he has biochemical relapse, but also some bone pain and lytic lesions. So I think there's no debate that we should treat this patient. So what are the treatment options for such patient? Well, we can find the answer, or at least try to find the answer, from some of the recently developed guidelines. So you have the EHA-ESMO guidelines, but you have also the IMW group and ASCO guidelines. And they are quite roughly similar. So I chose the IMW ones. And if you focus on the middle part of the slide, talking about early first relapse with len refractory disease. And the answer, you can see, is about using an anti-CD38 monoclonal antibody-based treatment. And the regimens being proposed are the daratumumab, bortezomib, dexamethasone, DVD, daratumumab, pomalidomide, dexamethasone, DPD, DKD, daratumumab, carfilzomib, dexamethasone, ISA-KD, cetuximab, carfilzomib, dexamethasone, or isatuximab, pomalidomide, dexamethasone. But we do have also regimens without CD38 monoclonal antibodies, and this is mainly about the PVD regimen, which is approved, pomalidomide, bortezomib, dexamethasone. Eventually KPD, carfilzomib, pomdex, not approved, elotuzumab, pomdex, not approved as far as I know, and so on. So let me show you the data that support actually this kind of recommendations. So don't worry, it's a very busy slide. I'll go through some of the key findings. It's just about to highlight actually that in this LEN refractory population, all these data, all these recommendations I mentioned are relying on large randomized phase 3 trials. On the left-hand side, actually, you have the doublet combinations, which actually are now, except in a few patients, are outdated, especially the use of carfilzomib, dexamethasone in the Endeavor trial or in the Arrow trial. Now, I think the key results are about using triplets. And the big choice is about either using an anti-CD38 plus something or without anti-CD38. And I will show you some of the data. I will not expand on elotuzumab pomdex because, at least for us, elotuzumab is not available, but I think in most places, elotuzumab is very rarely available. So I'll focus on things that are really being used on the ground. And the most recent, I would say, and very robust data we had in this setting are from the IKEMA trial. This is a large international phase 3 randomized trial comparing KD, carfilzomib, dexamethasone. This is the one validated and approved from the Endeavor trial, versus isatuximab, carfilzomib, dexamethasone. Isatuximab is a nice anti-CD38 monoclonal antibody. And for the sake of time, I will not go through the details of the mechanism of action, but the two anti-CD38 monoclonal antibodies are not exactly the same. It's not like, you know, a me-too or a copy and paste anti-CD38. The clinical relevance of the differences are more difficult, but we can discuss this. And this trial, IKEMA, was performed in those patients who were actually in early relapse. And there were a lot of patients in first relapse. And if you look to the primary endpoint, this is, I think, if there is one result to be highlighted today, this afternoon, I would draw kindly your attention to this one. Because first of all, the triplet isatuximab KD is doing better than KD. But what you should really focus on is this median PFS in a relapse setting of almost 36 months. So we're not frontline. Remember, for instance, in the first trial, Lendex, in the elderly population, first line, your median PFS was 2 years. Here we are in relapse, and we're talking about already a 3 years PFS. So you would imagine the amount of PFS one would accumulate between the first line and the first relapse treatment if one managed to get the optimal combination. So very important result, especially that when you look to the subgroup analysis, actually everybody, all subgroup of patients can benefit from this combination, especially the patients who were refractory to lenalidomide, but also the 1Q21, the 1Q plus patient. And this is more and more well established as a marker of high-risk disease. It's not only anymore about deletion 17p, but also we have the 1q abnormalities being a bad risk factor. The other trial we have from this field was anti-CD38 monoclonal antibody and carfilzomib, second generation proteasome inhibitor, similar to the IKEMA trial, is a so-called CANDOR trial, which actually similar to IKEMA compared DARA KD to KD alone. And again, this is about relatively early relapse, 1 to 3 prior lines of therapy. And the design is similar, with primary endpoint being progression-free survival. In this trial, you have patients who receive prior auto, other patients without prior auto, similar actually to the IKEMA trial. And if you look to the results, the latest updated results, we also have an advantage for an anti-CD38 plus carfilzomib and dexamethasone. So you can see at time of first relapse, in those patients who are able to tolerate a treatment with carfilzomib, because I think everybody's familiar with carfilzomib, you can't give it to everybody, we can discuss this. Clearly, the results of an anti-CD38 plus carfilzomib dexamethasone are quite convincing and appealing. The other scenario would be to say, for some reason, I don't want or I cannot use carfilzomib. So what are the alternatives? Well, in that case, it's about using a pomalidomide-based combination, because pomalidomide is a sort of a second generation IMiD. It can overcome resistance to lenalidomide, although there may be some cross resistance. We need to acknowledge this, but in general, you can overcome the resistance to pomalidomide, similar to carfilzomib versus bortezomib. You know, you can have cell lines which are resistant to bortezomib. They respond well to carfilzomib. And here we also have trials, randomized trials, like the ICARIA trial, which compared PomDex, and I think it's relatively now old regimen that is approved in many places across the globe, compared it to isatuximab, so again, my anti-CD38 monoclonal antibody, plus PomDex. And these were patients with 2 prior lines of treatment. So you can see it's very subtle, you know, when it comes to analyzing these trials. However, it is a very interesting trial, because although the patients are more advanced than what we have seen with the other trials, you still have some very good results, and you have a hazard ratio highlighting a 40% improvement when you combine an anti-CD38 monoclonal antibody plus pomalidomide dexamethasone. And it works whether you receive prior auto or not. And for the sake of fairness, I need to emphasize, to show that we have similar results with daratumumab PomDex, so the other anti-CD38 monoclonal antibody, and you have similar response rate, and you have similar results to what you have with the ICARIA trial. So you can appreciate that in the len refractory population, today, the most powerful and popular options we have in hand, what I would call first class option, assuming you're traveling, you know, first business class, economy class, are the anti-CD38 monoclonal antibodies plus carfilzomib or plus pomalidomide. As I mentioned, it's not our best choice, but for instance, PVD, pomalidomide, bortezomib, dexamethasone, can be an option because there is a randomized trial establishing the role of PVD in this population. However, I believe there's more to come, and the landscape would be even more confusing, in my opinion. I mean, it's always good news to have more options, but the bad news is that it makes our life more difficult. So what is about to come? We already, I think, have phase 1 data about this new family of drugs, the next generation IMiDs, which we call now cell modes. But at the end of the day, these are next generation IMiDs. And there are already 2 drugs being tested in phase 1 trials, namely iberdomide, but also mezigdomide. And they're very interesting because, again, we're talking about this IMiD family. They are even more powerful in terms of efficacy than the IMiDs we know, lenalidomide and pomalidomide, and hopefully they are now being tested in combination because there is a synergy in terms of mechanism of action when you combine them with monoclonal antibodies and proteasome inhibitors. But I think the most exciting part for the future, and the future can come very quickly, I think this is Albert Einstein who used to say this, it's about the different immune therapy options. And the different immune therapy options today are about, for instance, the antibody drug conjugates, for instance, belantamab, which is an antibody drug conjugate directed against BCMA. I'll not expand a lot on it because it's not widely available, and there are some concerns about the eye toxicity, especially it can induce keratopathy, and we need to work on the dosing and schedule. I think the most exciting part of this story is about the T-cell engagers, bispecific antibodies, and CAR T cells. And all of these agents, whether the CAR T cells or the bispecific antibodies, all of them are using BCMA as a target, as a tumor antigen. And so I thought to put one slide to explain why BCMA is a very attractive target in multiple myeloma. Well, first of all, if you look a wide spectrum of different malignant diseases, you can appreciate that the highest level of expression is in multiple myeloma. So clearly, this is good news, and it can allow you to define the patient population of interest. So what is BCMA? It's the B-cell maturation antigen. It's a member of the TNF receptor superfamily. It is universally expressed in multiple myeloma. And actually today we know that the frequency of losing BCMA expression after a BCMA targeted treatment is usually around 5%. So in 95% of the cases, actually the expression is there. And that's good news because when you look to other diseases in hematology, we know very well that unfortunately you can lose easily your target. If you consider lymphoma, for instance, or ALL, one of the mechanisms of escape to CAR T cell is about CD19 expression loss. In theory, BCMA, the probability of antigen loss is relatively low. The other good news, which make BCMA a good target, is that you can avoid the off-target toxicities. And when you look to the BCMA knockout mice, actually they are healthy with normal B cell, but reduced plasma cell. And that's great because you want to get rid of plasma cells. So this is very important. And actually, it allows me just to make a quick remark. This is why it is very difficult, actually, to develop CAR T cells in myeloid malignancies, in AML, in MDS, in myeloproliferative diseases, because your tumor antigens are also expressed in general on the hematopoietic stem cells. So you can eradicate your malignant blast, leukemic cells, but if you eradicate your hematopoietic stem cell system, you're lost. Whereas here, by targeting BCMA, by targeting CD19 and lymphoma, for instance, you are on the safe side. So for CAR T cells, I think everybody's familiar with the way CAR T cells work. You get your autologous CAR T cells. It's an apheresis, so nothing, I would say, technologically complicated. These lymphocytes collected by apheresis are shipped to a manufacturing facility, and this is why there is a delay and there is a sort of, waiting list, I would say. And there is the manufacturing process. And this is why I think we will have an amazing number of CAR T cell constructs, because of course you can play on the target. I told you the most popular one is BCMA, but actually 2 weeks ago we had a new construct published in the New England Journal of Medicine, and this is GPRC5D. So you can see, and the more antigens you have, the more you can target, you can build CAR T cell construct. An important feature of CAR T cells is the co-stimulatory molecule you're going to use. And then depending on what you use, usually 4-1BB is the most popular one, then you can design. So there's an amazing number of CAR T cell constructs that can be developed. So today we do have 2 CAR T cell constructs which are approved. The ID-Cell one, and that was approved thanks to the KARMA trial, 127 patients published in the New England Journal of Medicine. And actually, we already have real-world data about this because it was first approved in February 2021. And you can appreciate that these are patients who were heavily pretreated. They usually received a median of 6 lines of prior therapy, and still they do have a very important response rate. There are also university hospitals developing academic CAR T cells. I don't know whether this is feasible everywhere, but our Spanish colleagues are developing academic CAR T cells. And I will show you that we do have data with alternative target, but maybe in the future we'll have allogeneic CAR T cells. So let me just show you some of the results of the approved constructs, ID-Cell, the KARMA trial. You can appreciate we're talking about a response rate around 80%, which is quite decent, in a population heavily pretreated, highly refractory. And despite this, you can achieve a median PFS around 9 months, but also a median OS around 20 months. It is very important to highlight that when it comes to multiple myeloma and CAR T cells, in contrast to ALL or to non-Hodgkin lymphoma, we don't see a plateau, because today we do have more than 5 years follow-up, for instance, in relapsed refractory DLBCL with CAR T cells. And we know there is around 30% of long-term survivors. And in my opinion, they are going to be cured. That's not yet the case for multiple myeloma. Maybe this construct, the cilta-cel, which is the more recently approved one, is leading to better results, because you can appreciate that here the median PFS in the previous one, the median PFS was 9 months. This one has a median PFS which is around 24 months. And why is it different? Although the target is the same, this cilta-cel actually can target 2 epitopes of BCMA. So it's like, you know, you're having two guns and you're trying to kill your enemy with two guns. In general, you know, the likelihood of killing the enemy is quicker with two guns compared to a single gun. So that's how I try to explain it, although this may look a little bit very simplistic, but at least this is one speculation on why it works better. And what's clearly amazing is that in those patients who are able to achieve MRD negativity, and actually achieving MRD negativity even in the relapse setting now is becoming feasible in multiple myeloma, actually these patients are likely to enjoy some long-term outcome. Obviously, the follow-up is relatively short, 2 years, but it's a good start. And you would imagine tomorrow, if you move these cells into earlier lines of therapy, the results are likely to be improved. So these were the BCMA targeted constructs, but I told you that we have now another target, GPRC5D, and here I am showing the slides from one of the ASH meetings, but now you have access to the full paper in the New England Journal of Medicine 2 weeks ago, where Dr. Mail Cody has published this. And it's very interesting because you would imagine that if all of your drugs and treatments are targeting BCMA, at some point the patient is going to become refractory to BCMA. So this pathway is going to be lost. And you need other targets. And this is why GPRC5D is a very interesting target. The problem with autologous CAR T cells is that cost is there, of course, but this is something we can discuss. It's also about the logistical burden, and you need to wait for several weeks before getting them. And I'm not talking about the waiting list. So obviously having off-the-shelf products can be interesting. And that is the philosophy behind developing allogeneic CAR T cells. And some biotech companies are involved in this. And we've already seen some interesting results. I don't know whether they are convincing, but they are interesting. I would say it's a good start about the Allo715 trial construct with allogenic CAR T cells. Very small number of patients, but it looks like, for instance, if you look at the median duration of response, it's roughly similar to what you get with ide-cel, for instance, the autologous CAR T cells. So they're not so bad. The problem with allogenic CAR T cells is that you need persistence. And because they are allogenic, they are rejected. Actually, their safety is very good. And we have tested them and we contributed a lot, for instance, to allogenic CAR T cells in my department. In ALL, for instance, we published a paper in December 2020 in The Lancet. As earlier last week, we had an update in The Lancet Hematology about allo CAR T cells, and they work well. Your biggest issue is about persistence. Otherwise, the safety is absolutely amazing. And obviously, they are in your pharmacy. You just get them and infuse them. So very interesting, I would say, perspective. But you will see, as I mentioned, the future comes very quickly. And now, believe it or not, there are already ongoing trials. These are not planned trials. They already started including patients, namely, for instance, the CARTITUDE-5 and the CARTITUDE-6 trial. These are trials that are randomizing our standard of care today, for instance, in the transplant-eligible population, induction with DARA-VRD, followed by auto consolidation, Len maintenance. This is today our standard of care, and we can discuss what is your standard of care. And now they are randomizing against DARA-VRD, followed by CAR T cell. So it is likely in, I don't know, in 3, 4, 5 years, we may end up with a scenario similar to what we have seen recently in lymphoma in first relapse, where they have randomized auto transplant versus CAR T cells, and the winner was CAR T cells. I remember the ZUMA-7 trial, the TRANSFORM trial, and also the Belinda trial didn't show superiority of CAR T cells, but if you show similar results, given the better safety profile of CAR T cells compared to auto, well, obviously now, for patient with first relapse in DLBCL, we're offering CAR T cells to everybody. So we may have this scenario in myeloma in the next 3, 4, 5 years. It's also the same story in the elderly myeloma patient, where VRD, classical standard of care, not our favorite one because we use Daral and Dex, but still, you know, VRD is quite popular everywhere. It's a sort of a nice Mercedes, you know, it takes you a long way. And it is randomized, VRD 2 cycles, CAR T cell, and observation. And this is very interesting because it allows patients with CAR T cells to have a single shot treatment, you know, and that's very attractive because then, I mean, all my CAR T cell patients, even, you know, they are not cured, but when they enjoy like 2 years of treatment-free interval, it is amazing. You know, you have patients who would tell you, Saturday I was at the annual meeting of our patient advocacy group. So all patients are there with their families, kids. So it's a very nice moment to spend, you know, in the afternoon and have some tea and biscuits with them. And I mean, I heard stories from patients telling me, oh, I've been receiving drugs for 10 years. And since now, the first time in my life, I got the CAR T cells and I'm free of everything. Well, I said, that's great news. We cross our fingers that remission will continue, you know, for a long time. The second big players in the field are about the bispecific antibodies, T-cell engagers. And again, I mean, it's impressive, the number of drugs being developed. You have the anti-BCMA one, and teclistamab, I told you, has been approved by EMA. So it's the first time EMA approved something before FDA, by the way. I don't know about the South African FDA, but definitely the Europeans were very proud about it. I don't know what happened. Maybe FDA were on vacation or something like this. But clearly, teclistamab is approved. And we have also now bispecific antibodies looking into other targets like the GPRC5D, but also the FCRH5s. Talquetamab hopefully will be approved soon. Cevostamab is under development. And again, these are patient heavily pretreated, 5 to 6 lines of therapy. So in general, you would say almost palliative care patient. Still, you can achieve 60 to 70% response rate. And if you look to the teclistamab pivotal trial, which led to the approval, published in the New England Journal of Medicine earlier this summer, actually, you can see you have roughly 1 year of PFS. So clearly, in those patients where you wouldn't expect more than 2 or 3 months of PFS, the new standard now is about 60, 70% of response and more than a year of PFS. And you can see the results of the Majestic 1 trial, which led to the approval of teclistamab. You can appreciate 63% overall response rate and 11.3 months of PFS. And obviously, if the patient achieves CR or better, then they are going to do better. Obviously, you can tell me, well, these are patients with a better biology, but still, you know, they are doing well. I didn't mention the toxicity of CAR T cells. I apologize, I forgot about it. But actually, with CAR T cells in myeloma, we're not really facing big toxicities in contrast to lymphoma and ALL. So it's really less than 5%, no severe toxicity. What I'd like to emphasize, if you are going to use bispecific antibodies, this is something, it's a learning curve for us. We are now really discovering, and it's not clear, you know, from the papers. If you go to the New England Journal of Medicine paper about teclistamab, actually you have to go and dig deeper into the supplement, and the supplement is 424 pages, guys. So if you have time to spend, and you need to find the, you know, table number 19 point something to see, you know, the exact profile of the infections and so on. So to make a long story short, what I would like to emphasize to you that the big problem beside efficacy we're facing with bispecific antibodies is about the opportunistic infections. So they cannot be used everywhere, and they have to be used with lots of very stringent monitoring of viruses, but also fungal infections and very unusual infections. Just an example about those drugs with targeting a different target. This is the Regeneron 6234. And again, if you want to have the full details, it has been published in the JCO, I think 3 or 4 weeks ago. So I didn't update the reference, apologies, but I think you can easily find it in the Journal of Clinical Oncology. So the results are interesting, but GPRC5D has a very peculiar profile of toxicity. So it's not life-threatening toxicity, but patient hates it. So it's about dysgeusia, it's about dry mouth, it's about skin and nails problems. So people don't like it, I can tell you. There are very few patients. So it's very interesting. On one hand, sometimes you have life-threatening complications. On the other hand, you have like maybe mild complications, but really they can alter the quality of life of the patient. Cevostamab is still less advanced, but it looks very promising. And what I would like to emphasize is that now the technology is there, to do bispecific antibodies. So it's about finding the right antigen. But again, things move very, very quickly, because now, believe it or not, we'll start testing the tri-specific antibodies. But in the meantime, actually, the next step is about trying to bring these bispecific antibodies into earlier lines of therapy. And there are ongoing trials now, the Majestic 4, looking into combining teclistamab and lenalidomide, for instance, in newly diagnosed multiple myeloma patient, for maintenance, for instance, against lenalidomide. But also our group, the IFM, is going to start soon in non-transplant eligible patient, a very simple, I would say, trial comparing DARA teclistamab to teclistamab and lenalidomide. So just building on standard of care. So if you compare CAR T cells and bispecific antibodies, obviously I mentioned the logistical burden and the delay in the availability of CAR T cells. Antibodies, bispecific antibodies are off the shelf. In the trial, the patient population, in my opinion, are roughly similar. If you look to the severe toxicities, as I mentioned, they are relatively low, but a word of caution about opportunistic infections with bispecific antibodies. And when you look to the median PFS, we're talking about something around 1 year, and probably with cilta-cel closer to 2 years. So in summary, I hope I have convinced you that the treatment of relapse is really moving rapidly now. We're stuck a little bit with the len refractory patient, but we do have options for these patients, although we need to have some sort of an intellectual, I would say, flexibility and plasticity in our brain to try to find the right combination for the right patient. Today in October 2022, we believe that anti-CD38 monoclonal antibodies, like for instance isatuximab or daratumumab, plus Pomdex or plus carfilzomib dex, are really the standard of care combinations. But in the future, I think we will see the advent of bispecific antibodies and CAR T cells into earlier lines of therapy. So with this, I'd like to thank you all for your attention. And of course, I'm more than happy to take questions and comments. Thank you very much.
Thank you, Professor, for a really fantastic overview. A lot of that is like far from us, the bispecifics and the CAR Ts and bringing them up front. And I'd like to get there just now, but I think maybe we could really start about this lenalidomide refractory, because there's been some interesting comments in the chat there. So if we're saying that if you become lenalidomide refractory, you're in trouble, we understand the principle that you use your best things up front, you get the patients into the deepest remission and get the best response. But it almost raises back that old question about should you be saving something for later? So Dr. Malherbe said in the setting where you don't have all these fancy drugs, is it still best to start with BRD and transplant and len maintenance? Or can we now possibly argue it might be better start with VCD and keep len-based therapy for relapse?
Yeah, no, I think as usual, Karen, you have the right and most accurate comments, and I think there is no single answer to this. It depends on your environment. In general, my philosophy now more and more is to say, I will not save my best bullets for the future, because there will be always something more. But of course, I'm more than happy to adjust to a very specific environment where I know very well that it will take me some time before getting whatever new option. So in general, based on my original comment on the fact that 80% of the survival is achieved in the first line and first relapse, it becomes clear that you have to use your best options as soon as possible, because actually your disease will become more and more resistant at time of relapse, and even your so-called best bullets or best guns will not yield good results even if you spare them. That's our philosophy for the moment.
And then I think a really important question, Dr. Ashmore sort of alluded to it, but we have a kind of in-house South African view that if you're on lenalidomide maintenance and you relapse, you're not necessarily lenalidomide resistant, and you can just increase the dose. Would you agree with that? Or?
Well, that is a recurrent question, I would say. The short answer to this is that if you have a true disease progression while you are receiving lenalidomide, this is a definition of resistance to lenalidomide.
Regardless of the dose.
Exactly. Having said this, this is what has been shown, for instance, in the IFM 2005 2 trial, which tested lenalidomide maintenance. However, I think most of us are really, practicing physicians, seeing patients. I can give you the example of one of my patients who has been receiving lenalidomide like for 7-8 years maintenance. And this patient relapsed, and he sent me, it was during COVID, so we were doing telemedicine. So he sent me, by email his results and said, oh, we need to figure out, something, maybe we can wait for a couple of weeks until the situation improves. And spontaneously, this guy took the initiative, the patient decided, he's a smart gentleman. He increased his own dose because actually after 7 or 8 years, he's probably accumulated some, boxes of lenalidomide, because obviously he was lying to me from time to time, taking some holidays, 1 month here, 1 month there, but we like patients as they are. And then, he increased himself the dose. And when he came to see me, actually his monoclonal comment almost came back to 0. And I said, hey, come on, what happened? I mean, was it a mistake from that? What did you do? And he explained to me that he increased the dose, and actually it proved. So there are anecdotal, I would say, situations where it can work, but in my experience, this is less than 5% of the patient. If for some reason, your local regulation environment says, well, okay, you have to increase it. Okay, we can increase it, for 1 month if there is nothing aggressive and life-threatening, and if you see that it's not improving, well, definitely there are resistance. So, but I'm not against, increasing it for 1 month if this can help the regulation to move forward.
I've also definitely seen that of patients with, because we don't have all the millions of options here, by increasing doses, we get somewhere. Do you think there's something about combinations? Could a drug not work in one combination, but it could still be a synergistic addition in another combination?
Yes, absolutely. I fully agree with you. And for instance, we've seen this. So I don't have the pathophysiological explanation, is just pure clinical observation, you know. We've seen patients who received CAR T cells, and these are patients who were resistant to everything in theory, because we are allowed to do CAR T cells only in case you have used everything. But then, you know, they relapse after CAR T cell, and then what to do? I looked, you know, I usually, to decide, go to the list of all the treatment they received, you know, put my shot, what did they receive, what dosage, for how long, and what was the response. And then, you know, you have this magic recipe in your brain where you say, well, okay, he was quite, he didn't receive, you know, bortezomib for a long time, and he responded, why not using it again? And suddenly, you know, the treatment that was supposed to be not effective is working. So clearly, there is also, there are changes in the microenvironment where some treatments can work again. And the best example is usually, and that we are, I think, neglecting more and more, is about bortezomib. Because usually patients don't take bortezomib for a long duration. So they keep on being sensitive to bortezomib, I think. So please don't neglect bortezomib.
We also talk a little bit about daratumumab sometimes resetting the clock. So patients who you've gone on to dara, and then, as you say, we get stuck and we don't have all the options. After daratumumab, we see patients going back to response to previous things. Is that documented? Is that a realistic thing or not really?
That's very complicated. And actually, although we have a good picture, good idea about resistance to IMiD, we don't have a great idea about resistance to anti-CD38 monoclonal antibodies. So, for instance, we don't know whether one anti-CD38 can overcome the resistance to another one. This sequence, although I must confess, I had patients who were treated with daratumumab in the time of relapse. We gave them isatuximab plus something, and it worked very nicely. Because these are not really me too drugs, you know. They have different mechanism of action. The target is the same, but they have different mechanism of action. So in general, we don't know how this can translate into a benefit in the overall population, but in some cases, it works, you know, to switch from one to another, or to use another combination with anti-CD38. And some people in the myeloma community are advocating, saying, well, it's like rituximab, you should keep on using it. Because actually, although CD38 expression can be downregulated, but actually after a few months it goes up, and there are tools to push it up. You know, you can use ATRA, for instance. Obviously, there's a blood paper showed that you have a proof of concept, but it doesn't translate into clinical benefit. You know, if for some reason you're able to use an EDGE-DEC inhibitor, an EDGE-DEC inhibitor can upregulate, you know, CD38 easily. So yeah, I would say why not? But again, it depends on the what's available in your pharmacy at the end of the day.
So there's no specific data saying you can change from one anti-CD38 to the other and get benefit. There's no trials showing progression from one to the other.
To be totally fair, there is one publication, I think, in leukemia, and the first author is Xavier Leleu, who tested this, but in a very advanced setting and with single agent, which I believe is not relevant anymore to the way we use anti-CD38 monoclonal antibodies. But for the sake of fairness, I needed to mention.
So essentially, in our setting, when we have limited options, one really does have to try and circulate and change in the hope that you may get some alternative synergisms that will change things. I think it comes to Jacques Malherbe's comment here. He said, while the overall survival curve in the initial slide on of transplant versus VRD alone looks amazing, with nearly 80% alive at 8 years. So this is alluding to the publication from Richardson. The progression-free survival curve is less than 40% progression-free at 8 years. So one can assume that the overall survival is a reflection of the other lines of therapy, and we just don't have those available. So really, in our setting, it's an interesting thought. Where are we?
Yeah, I mean, I agree. This is a very wise comment, although the exact figures of PFS at 8 years is around 50%, not 40%, but that doesn't change anyway the reasoning. I agree. Yes, that's true. This is about the other lines of therapies, but I don't believe this is about line number 15 or 17. This is likely in this trial, if you look carefully, these are patients who, at least when you discuss with Paul Richardson, and we did a similar trial, you know, the IFM 2009. Actually, this American trial, the determination trial, they called it, is a copy and paste of the IFM 2009 trial, which was published. And when I'm saying copy and paste, it's not negative criticism. It was, from the beginning, designed as a copy and paste, you know, a mirror trial. In the IFM, we tested only 2 years of maintenance, whereas the idea in the American trial to test continuous treatment. That's the only difference. So yeah, I agree that obviously subsequent therapies are contributing to the overall survival, but it is mainly related in this trial actually to the treatment you have given at first relapse. And this is about giving them an anti-CD38 monoclonal antibody, pomalidomide or carfilzomib.
So I think, and I'd like to start to talk about the monoclonals and the bispecifics, but because they are a step away from us, our optimal management of relapse has to be about finding the right combinations, and as you say, dictated by what's available. But there are signals that certain drugs work well together, like anti-CD38 antibodies and IMiDs, because they both activate T cells, and you should get that. And then the ELO and the SLAM-F7, so are there specific combinations of drugs that might be the best put together, or is it just a case of putting them all together and seeing how they work?
Well, interesting, because obviously if you read the papers, there's always a lot of great and fantastic science behind everything, you know. But I always give the example of the combination of bortezomib and lenalidomide. I mean, if you read the papers, you would have never combined these two agents because they are like antagonists. But today, who cares, I would say. So yes, there is in general a scientific rationale, but when I look to, we contributed a lot to the IKEMA trial, to the Candor trial. The reasoning was very simple, is to say, well, these guys failed lenalidomide. They have received bortezomib. We want to give them the so-called second generation. It was very simple. Obviously, there were no signals telling us you should not put them together. I think we need to reason the other way around, is whether you have a sort of a negative signal that would tell you, oh, be careful, don't put them together. Otherwise, it's highly empirical in my opinion, but that's my personal opinion.
And then, I mean, I know you're not allowed to compare between trials, but this Castor and Pollux, the difference between DRD and DVD was massive. And now you've just shown us again with the Icaria and the chemo trial, the ixazomib with POM looks so much, well, not nearly as good as ixazomib with carfilzomib. Is it really huge differences in the trial, or is this a signal that there's?
Yeah, no, I like the story that we're not allowed to compare trials, but we are allowed to look into the results. So this is how I turn it, you know. Yeah, clearly these are different populations. The patient in the ICARIA trial are more advanced, in my opinion, than the IKEMA trial. That's one point. It is also, and I think I alluded to this, that there is some cross-resistance between pomalidomide and lenalidomide. And these were patients who were refractory to lenalidomide. So at the end of the day, if you are able to give carfilzomib to a patient, our first option today in my department is to give isatuximab carfilzomib dex, because having 36 months PFS, we've never seen this in any previous trial.
Well, DARA-RD.
Well, DARA-RD, but you need to be lens sensitive. That's the issue. I'm talking mainly about that. Of course, in case you are lens sensitive, DARA-RD, and we have now even survival benefit with DARA-LenDex. But these patients are becoming very rare. And I can tell you, because I follow this very closely, I'm myself the PI of one of the IFM trials with DARA-LenDex, fixed duration versus continuous duration. And we started this in 2017, and I can see progressively, you know, the number of patient eligible decreasing, because everybody is becoming more and more refractory to lenalidomide, unfortunately.
If anyone's got any questions, please type them in the chat or raise your hands. Also, cases I think would be quite interesting to discuss. Can I just, in the absence of anyone right now stepping in,
Karen,
just ask, yes.
Sorry, I just want to quickly throw in an advertisement here. One, the link for the CPD has been posted in the chat box. So if you can just click on that and quickly do what you need to do. And then second, while we still have a large number of people in the room, I was planning to do this at the end, but I'm afraid that some people have to leave earlier. I just want to say a special word of thanks to Sanofi and specifically to Nondumiso Makunga Stevenson, she's in the room, for kindly sponsoring this session with Prof. Moti. And yeah, so I just wanted to mention that before too many people have left us. Thanks.
Thanks, Vernon. Yes, we're always so grateful to pharma for enabling these meetings. Can I tackle the issue about continuous therapy, second line? So, you know, first line, we kind of have a kind of limit and we wean down, we go on to maintenance. Supposedly second line, you're supposed to go on full therapy till progression. And clinically, that's very difficult. Is it reasonable to start weaning down the dex and changing doses? Do you do that?
Yeah, you nailed it very nicely. Now, thanks, I would say, to the COVID. Maybe we try to see some positive things about COVID. We learned progressively that once patient responded, you can easily try to decrease the dex dose, and we rarely now give the full dose dex dose. And I can tell you that our next trial about to start is a dex-free regimen, you know, even in the relapse setting, where in other words, they will get 2 cycles with dex and then we'll stop it. We'll randomize it, of course, but we believe that we are annoying the patient a lot with the side effects of dexamethasone. And today, I think we can be brave and try to get rid of it, or at least decrease it. So I have rarely, very few patients receiving 40 milligram, 20 milligram is the maximum, and now I have more and more patients receiving 10 milligram or even 4 milligram.
I think that's really just quite helpful from a practical point of view. And one other sort of practical question, Antonio Palumbo always used to say, alkylating agents are useful in older patients. Do you think that's still true with all these new drugs? Should we be looking at a little bit of VMP adding cyclophos in older patients?
Yeah, fully agree. I think it's still a very wise decision, because more and more when I see these patients for a second or third opinion, and when I look into the treatment they have received, sometimes you're astonished that actually they've never received melphalan or cyclophosphamide, and then you get, you know, they've been sent to me like because they are in palliative care, and you say, okay, why don't we give you some cyclophosphamide and prednisone? And you know, 1 year later they're still around, and they say, oh, that's magic, you know. So yeah, we need to pay attention to this, because with all our excitement about the novel, fancy new drugs, we should not forget that there are relatively cheap, easy to use drugs, especially in the elderly population, in patients who are advanced, and there are good multi-myeloma drugs, yes.
I think that's just important from our point of view to remember. Perhaps I can end, if there's no, with a case to just give you an example. Is that okay? Everybody got a bit of time? So just a patient, he was 69 when he presented to 2017. He had a DAL1Q. He got VRD. I would have transplanted him, but he had friends in America who said he shouldn't be transplanted, so we didn't. And we put him onto maintenance, dual maintenance, because of the high risk. So it was in Velcade every 2 weeks in low dose len. And he did progress. The response from there, again, wouldn't have been much. I was supposed to increase the doses, and it worked. So we went back to full dose. He went back into remission. Then the strangest thing happened. We swapped to ixazomib for a month. And then he got autoimmune hemolytic anemia, which in fact was more related, it seemed, to the lenalidomide than the ixazomib. Then we kept him on a very strange regimen, and then I mutinied from the American advice we were getting and put him onto Darapomdex, thinking I would go that route. And he had a fantastic response, and then within 1 month it was bumping up again. Then I added some bortezomib. I didn't want to add carfilzomib. I was a little concerned about from the cardiac side. Basically, he's got very rapid progression, and I'm a little bit stuck now. Where are we going with that? So does it have to be immunotherapy?
Yeah, well, the first teaching from this story is that he should bet more trust, I think, his South African doctors than the American one. That's one point. The second point, yes, this guy is definitely the ideal candidate today for us for the immune therapies, whether bispecific antibody. These are the, I mean, if you send this patient to me, this is what I can do immediately because they are available quickly. CAR T cells are going to be more complicated because the waiting list is very long. But this is the, I would say, these are the options, the fancy options. Now, if these options are not available, then I would say it's about trying to find a cooking recipe from all the agents he has received in the past and try to figure out whether something can work.
Like
For instance, sorry?
Like bendamustine.
Bendamustine is not so bad when you combine it with bortezomib, you know, BVD, which the IFM published in a hematologica paper. I mean, it's not magic, but it's interesting. I'm not convinced 100% it's better than cyclophosphamide, but still, I think it's an option.
If we can stand on your toe and just keep you a little bit longer, there's a case from Dr. Justin DeToy. It's a 54-year-old man with a refractory myeloma. He got 6 cycles of VCD with no improvement, still 90% plasma cells in the bone marrow. He's on dialysis. There's no access to daratumumab and carfilzomib. What would you do?
Well, I would definitely add lenalidomide.
Yeah. At low dose.
Yeah, 5 milligrams 3 times per week. There are some very good recommendations on how to use it when a patient is receiving hemodialysis.
And something like PACE or some sort of chemotherapy?
Well, I mean, I don't know how fragile is this patient. It looks like this patient is relatively fit, apparently 54-year-old. So I would start first with VRD and then figure out the question for this patient, in my opinion, and that brings us back to the story from 20 or 25 years ago, where you may remember the recommendation from all cooperative groups, and there is a paper from Joan Blady, I think, in the British Journal of Hematology, saying, well, and that's a time when we used VAD, you know, and the patient failed VAD, vincristine, erythromycin, dexamethasone, is that try to proceed to auto transplant, because you can still salvage 40% of these patients. And hemodialysis by itself is not a contraindication to perform an auto transplant, but it depends on your environment, your ICU doctors, your dialysis doctors, and so on. But one way of salvaging this patient would be obviously to introduce lenalidomide or even thalidomide. Thalidomide is even easier to manage with kidney failure. But also, why not considering high-dose melphalan, an intermediate high-dose melphalan?
Yes, that's interesting. That's an interesting thought. I would love to go on, but I think we do have to stop. Really appreciate so much insight and realism as well, which is really a valuable combination. So thank you so much for the information and the discussion. And yeah, we just really appreciate you. You're such a good friend to South Africa. I hope we see you here again in person fairly soon.
I really enjoyed it, and I hope we'll see each other very soon. But it has been a true delight to be with you today.
Thank you.
From my side, I just want to say big thank you, Prof. Moti. Big thank you to Karen. Thank you to our team. I showed their pictures a few times earlier. Prof. Estelle Verberg, Dr. Gerdien Kritzinger, and Melanie Davids for all the help to get this weekly meeting organized. And there's so much that happens behind the screens. Also to Blood SA for all the work done in hosting the sessions online. And for all of you who came, it was a good session. We had more than 110, 115 people here. And Prof. Moti, if you think about it, that we only have 45 hematologists for the 60 million people in South Africa, the attendance was not bad. And again,
wow, very, very impressive.
Again, a big thank you to Sanofi for the sponsorship, and Prof. Moti, we wish you all the best. We look forward to see all these exciting things coming to fruition in the very near future. Like you said earlier, that may the future be close to us, and hopefully also may our patients get the access to many of these new treatments here in Africa. We wish you all a wonderful evening and safe travels if you still have to go on the road. All the best, and thank you very much.
Thank you very much. Good night.
Good night.